The coronally position flap. The coronally position flap is the simplest way to get root coverage and certainly should be used before considering Class 5 restorations, providing 5 criteria are met. And those 5 criteria we will go over several different times during this video. Here we see a situation where Class 5 restorations were done on the lateral incisor, the canine, and the first premolar. And certainly the restorations are gone on the lateral and the first premolar, and we have a defective restoration on the canine, and you can see the irritation that restoration is causing. So the question comes up, can you treat this without grafting? And the answer is yes, and this is how it was treated, and this is a long-term result. Using the coronally position flap. No grafting was necessary in this case. There are 5 criteria or factors that need to be considered and must be met. So let's go through those briefly. First of all, you have to have a Class 1 recession. Number 2, you've got to have a type A or B papilla. And that's a term that you probably don't know, but we will discuss that in a moment. Third, you need to have 3 millimeters of keratinized tissue vertically. 4, that keratinized tissue needs to be 1 millimeter thick. And also, you have to have a minimum amount of missing root structure. Significant root structure needs to be replaced by some type of graft to give the contour that you want. Class 1 recession. Let's review for a minute the new classification or the modified classification that I recently published in the compendium. I think it was the September 2018 issue. All right, these you are familiar with because these were from the classic article in the 1980s. Marginal tissue recession, which does not extend to or beyond the mucogingival junction, and there is no bone loss or soft tissue loss in the interdental area. But the key factor here is if there was gingiva on the facial, we consider that a Class 1. But the important thing and the distinction on the reevaluated concept that I presented in the compendium was if you have keratinized tissue on the facial, it has to be attached. If it is unattached, that makes it a Class 2. So let's look at that. And there's no way to determine this unless you use a probe. Here we see about 1.5 millimeters, 2 millimeters of keratinized tissue. Is that a Class 1 or is that a Class 2? But then you'll notice as we probe, that probes beyond the mucogingival junction. So any gingiva on the facial that is unattached throws that over into a Class 2 recession. But let's take a moment now to review and discuss gingival anatomy. In practice, and I hope you will do this as well, on any case you're treating with recession, you should always use pictures because pictures explain it to patients so very much better. And here we've made a pencil mark on this Class 1 recession, which we're going to use the coronally position flap on, and this lets the patient determine or actually see where we're going to get root coverage to. But let's go further. Here we see the cemento-enamel junction that is marked. Here we see our mucogingival junction, and here we see the attached gingiva, which is separated from the unattached gingiva by the free gingival groove. And certainly we have 3 millimeters of keratinized tissue, and you can just visualize this being a normal to a thick biotype, and we know that that is at least 1 millimeter thick. So any dentist who's interested in doing surgery, be they a dental student or a general practitioner, a restorative dentist, should be able, if interested, to do the coronally position flap on this tooth, as long as they have evaluated and diagnosed it and have met and realized that it's met the 5 criteria. So, just to reiterate it, Class 1 recession, A or B papilla, and the new classification of the interdental papilla. This is the article that was published in the compendium in September, where we discuss and actually for the first time present in the literature type A, B, and C papilla. Perhaps I should have published this as a separate article, but at this point it has been published, so look in the compendium and you will see that being published. So what are the types of papilla? We talked about an A or B, but there's also a C. First of all, a type A papilla, there is no interdental bone loss, and the papilla fills the embrasure space 5 millimeters from the crest of the bone, and the papilla is at least 3 millimeters wide at the cemento enamel junction. Where did we get the 5 millimeters? From this classic article by Tarnow and his associates back in the 1990s. A type B papilla is almost exactly the same thing as a type A. There's no bone or soft tissue loss in the interdental area, and the 5 millimeters still applies, but the difference is it is a narrow papilla. It is less than 3 millimeters wide. It may be 1.5 millimeters. It may be 1 millimeter in the lower anterior area where the teeth are crowded. But why is that important? The wider the papilla, the easier it is to tunnel underneath it without tearing it, and certainly that supplies a greater amount of blood. But an important thing on it is when you're trying to do the sutures to coronally position the flap, if you've got a little narrow, thin papilla, trying to get the suture through there without tearing it becomes a problem. A type C papilla is only found in a class 3 recession, and this means that the papilla is reduced and there is interdental bone loss. Very, very simple. So take time after viewing this tape or after this webinar lecture to go back and review that and fix that in your mind. So here we see on the case we saw, we got a type A, or actually probably an A plus papilla. But look how much blood supply that's going to provide. Look how easy it's going to be to suture. Look how easy it's going to be to tunnel underneath that without tearing it. So let's talk about the importance of papilla type and where I really learned this concept on this case that was treated many, many years ago, actually before we had osseous integrated implants. And the treatment plan on this, the patient was sent to me to augment the edentulous tissue on the facial so that an ovate pontic could be done using the Siebert classification. And that central incisor with a severe recession was condemned, and we were going to do a 4-unit bridge. That was the basic concept. So we were using the free gingival graft, and you will notice here on this case that I have included the papilla between the centrals to help stabilize that graft. And that graft has the vertical stabilizing sutures and the apical stretching sutures, but it does not have a final suture, which was the vertical stabilizing suture, and this is a case where I learned about that. And under another video, we will go through the suturing technique on that, but I just wanted you to see this particular case. So why did I use the mesial? Because I needed 3 areas for suturing to stabilize the graft. Now, we allowed for that to heal, and lo and behold, what do we see here? Yes, we got some root coverage, so I guess I thought it was a class 2, but it was a class 3 because we got some root coverage. Is that tissue 1 millimeter thick? Yes. Do we have 3 millimeters of keratized tissue? Yes. Are we missing any root structure? No. So now I said to myself, why don't we attempt to coronally position this and see if we could get more root coverage? So we take this, and now we see where I have coronally positioned the flap. But it's not coronally positioned, it's obliquely positioned. As you notice, the 2 vertical incisions are oblique but parallel. But look at the papilla between the 2 central incisors. That's only about 1 millimeter thick. And trying to place a suture in there, as well as on the distal of that, and snug that up around the tooth, is impossible because that papilla is so skinny. So that would be a B papilla, but it's on a B papilla. But if I had made that incision and angled it more, then I could have had a papilla that was 3 millimeters wide, and I could have taken a suture through that. And I could still have avoided the frenum. But when I did this case, what I'm telling you now, I had no idea. But this is a case, I guess the case that I learned more about than any case I ever treated in practice. So anyway, this is the way it healed up sometime later. And now the question is that central incisor a hopeless tooth? It's not mobile. We've got it's a class 3 at this point, and we could now go in there if I wanted to do a third procedure and actually get some root coverage on the distal. So the patient is still wearing the flipper partial, and remember, we had told her that tooth needed to be extracted and a 4-unit bridge done because this case was done probably 35 or 40 years ago. So this is where we started, and then about 20 years later, the patient was waiting to lose that central incisor and never had it extracted, and came back in on a referral from another dentist for problems in the posterior area, and all of a sudden we photographed that, and now we have a 20-year period. So this is an example where periodontal surgery literally saved a tooth. And now look at the tissue contour in that lateral incisor place. That would now be a very, very simple single tooth implant, immediate emplacement. So therefore, let's not discount periodontal surgery for saving teeth. So we go over the coronally positioned flap again, just for emphasis. You've got a class 1 recession. You've got a type A or B papilla. You have got 3 millimeters of keratinized tissue. But now let's look at how much vertical keratinized tissue we have. And this is a long-term article, a long time ago, 1972, where Lang recommended that 2 millimeters of keratinized gingiva, 1 millimeter of attached gingiva is adequate to maintain gingival health. While that may be true, is that something that you're going to be satisfied with? Because if you have a 20-year-old patient and you've only got 1 millimeter of attached gingiva and significant recession, is it realistic to think that that is going to hold up for the next 60 to 70 years? I would actually prefer to have much more gingiva than that. And I tend to adhere to what my colleague Gary Maynard recommended about the same time, 1979. And he recommended, especially when you're doing subcrestal margins, where they're anticipated, that you have 5 millimeters of keratinized gingiva with 3 millimeters of attached gingiva. And I think that we need 3 millimeters of attached gingiva, so that gives us what I talked about before. Now, how thick does that need to be? Well, we used to say it had to be thick enough until Baldy published this article in the late 1990s. And what he did on this, he took a number of cases and he coronally positioned the flap and found that if the gingival thickness was 0.8 of a millimeter thick, then he could successfully coronally position that. So I have rounded that figure off to 3 millimeters, but this is where we have, in my opinion, scientific evidence and a reference on this as to how thick the gingiva needs to be. So that comes to what I refer to as the Miller rule of thumb. If you're going to coronally position tissue, you need 3 millimeters of keratinized tissue vertically, and it needs to be a millimeter thick. Again, the criteria that we're talking about on there, just to reinforce and reinforce and reinforce that. Because if you do not understand this slide, you're not going to be able to diagnose the problem and actually treat it. So now we go back to the case that we showed you earlier, one of the first cases that I did. And the first thing we need to determine, is there missing root structure on the canine? There's no missing root structure on the lateral where that restoration came out. And how long does a class 5 restoration last? 3, 5, 7 years? And in this case, I don't know when they were put in, but they're gone now. So the first thing that we did, there was an overhang which was causing that inflammatory response. And I simply took a curette and hooked it over and pulled that facially. And you can see where the restoration fractured. But we got lucky on that. Just like on the lateral and the premolar, there is no missing root structure on the canine. And look apical on the canine. Is that tissue greater than 3 millimeters vertically? Yes. Is it greater than 1 millimeter thick? Yes. Are they class 1 recession? Yes. No missing root structure, wide papilla, apapilla. Now, this case was properly diagnosed because it met all 5 of the criteria. And this is the result that we got as we showed you earlier. And we're going to come back and show you how that was treated when we talk about different ways of doing the coronally positioned flap. But look what's happened when you put in a class 5 restoration. And this case was done before there was dentin bonding, and a composite restoration was placed, which required a preparation. But here we've removed the restoration. You can see the concavity in the root, but more importantly, you can see where the enamel has been undermined. So therefore, we're going to have to flatten that root surface, but also we've got to remove that undermined enamel, which is going to make that central incisor shorter than the other central incisors, which is going to present an aesthetic compromise simply because a restoration was placed. Now we're going in there after we have flapped the area, and we're going to talk about how incisions were made, and we're using a dental burr to get rid of that concavity so that the flap can actually touch that area. So we can see where the papilla has been elevated, but what I want you to know on the mesial between those centrals, how I have made that oblique incision, I have skirted the frenum. It's not going to be a reposition, but in a minute you're going to see that this is a type A papilla, and it was very simple to suture that. And we're going to talk about deepithelialization of the papilla a little bit later. So this was the Papilla Deepithelialization technique. But this is what I'm talking about. Notice the gloved finger and the lip is well elevated. So in doing any type of coronally position flap, you have to go way apically on that. And quite frankly, I made the incision or reflected the tissue all the way to the apex of these teeth, because this flap should be able to be placed where you want it, the lip raised as we're doing here and not elevated. And you will notice the oblique incisions. You will notice the frenum has not been coronally positioned, and you notice that we have a nice type A papilla for doing a sling suture with a papilla on the distal of that central incisor. So here's where we started, and this is where we ended up. Notice the gingival asymmetry caused by the fact that we had to undermine the enamel on that central incisor. But here's what I want you to see. Look at the difference in the contour of the root on the central that we grafted compared with the normal central. And what we want, we have, although we do have attached gingiva on that tooth, it is convex, it is concave, and therefore reflects light differently, and we see how red that looks compared with the convex tissue on the untreated central. To avoid that, this is a case that in this day and age would be misdiagnosed, because we do have too much missing root structure, and some type of graft should be placed underneath that coronally positioned flap to create a convex tissue rather than a concave tissue. So here we see the size of the graft that should have been placed under that coronally positioned flap. Yes, I would have still used the coronally positioning technique, but I would have replaced the missing root structure with some type of graft material. All right, now let's get into the 4 methods for doing the coronally positioned flap. And here they are. Papilla Deepithelialization technique, which was shown on the 2 cases that I've already shown you. Second is the tunnel technique, which was presented by Allen, in my opinion, in the late 1990s, and actually changed my classification of recession, because using the tunneling technique in some shallow class 3 recessions, you can get complete root coverage, or a combination of techniques. And finally, I'll give you my ideas and some thoughts since I took the pinhole technique. So here's a case we've looked at several times, the Papilla Deepithelialization technique. Okay, we've gone in there, we've removed the restoration as we said, but then we're going to go through this, and this is diagrammatic, and the suturing is a little bit different, and we'll talk about that. First of all, starting at the line angle on the central incisor, we made a split thickness. And what we're going to do on that is we see on the canine exactly how much tissue that we want to coronally position. So from the distal line angle of the lateral to a point, and then from that point to the canine, that is going to be split thickness. And therefore, the upper dot is going to be the new papilla, which is going to be brought down to the deepithelialized but not reduced papilla. In other words, the papilla height will not be reduced. We're just going to remove that epithelium. So when that is brought to place, that's going to fit exactly, because the distance between the dots in the papilla area and the dots on the canine are equal. So let's talk about the incisions. That split thickness, that split thickness. Then over the prominence of that lateral, it's full thickness, then a split thickness, then a split thickness, and a full thickness over the canine, split thickness, full flap over the premolar, split thickness, and although we went over, that should diagrammatically have gone straight up. And again, remember how far apically you're going to have to undermine that tissue, because in this case, I was able to bring that flap and pull it down practically to the incisal edges on these teeth to be sure that is well mobilized. Failure to mobilize the flap is going to create problems. So well mobilized, very, very important. Now, this shows using a barred Parker where we're undermining that, and then if you want to use tunneling tools to go further apically, whatever, but be careful not to perf the flap. So this is our incision. Now, that shows how well mobilized the flap needs to be. Well mobilized. Now, here we see the epithelialized papilla, and we want to take a barred Parker blade. Usually a 12B works very well on that, and we want to fillet off and expose the connective tissue underneath. Now we have a nice bleeding surface to support that flap as we bring it down, and you will notice that we did not reduce the papilla height. So this is where we've brought the papilla down to diagrammatically, and we're ready to suture. And we're going to demonstrate here the outbound suture versus the inbound suture. And this is going to point out the principle, but we're going to go into this in more detail on a couple of other cases. Here we have a terminal papilla between the central and the lateral. And on that, you want to pierce in the keratinized tissue a good distance apical to the tip of the papilla so we don't tear the flap. So the terminal papillae would be between the central and the lateral and between the first and second premolar. The dotted line shows where the suture goes behind the teeth. Now notice that the next suture is not in the middle but is off center. And diagrammatically this is not correct, because that suture that's on the mesial angle of the canine should be on the mesial surface of the lateral. And I think you can then visualize how that's going to snug that tissue close around the lateral. So you have two interdental or intermediate papilla between the lateral and the canine, the premolar. That papilla is going to be pierced twice, and the terminal papilla that we talked about between the central and the lateral and the premolars is in the center. Then we come back and you can see where another suture was placed at the line angle, and can you not imagine how that is going to really snug that flap against the tooth. So this is the outbound inbound suturing technique, and we will emphasize that a little later, and that is the result that we had several years later. Okay, the tunnel technique. And I give Andrew Allen credit for that. Pat Allen has done work on this and other people. But the principle of tunneling under this papilla without flapping and coronally positioning, I think, is an excellent treatment option. The interesting thing on this case was treated by a resident in the advanced graduate training for general dentist. She finished dental school, late May, early June, and she did this case under my supervision in October. So with proper instruction, a dental student should be able to do this if the diagnosis is made properly. And here we see the amount of keratinized tissue that we have, and I would classify this as a thick biotype. And that's very important because we are missing root structure. We were prepared to do a graft underneath this if necessary, but let's go through how this was treated. I think root preparation is significant, and because these areas of recession typically have no calculus, but the root surface is glass thick, and I think that needs to be roughened to expose the collagen fibrils so that the flap can attach to that. And on the left, you can see that we are doing classic vertical root planing, and on the right, you see horizontal root planing, and please note how the finger rest is there. The finger rest, as you well know, is extremely important in root planing. And if the cemento-enamel junction is very prominent or is slightly undercut, you want to take a burr and simply round that over as we're doing here. So I like to use some EDTA. We used citric acid for many years, but we did get some cases where we had root resorption. And so therefore, presently, I'm advocating EDTA to remove the smear layer, and I think that needs to be applied for about a minute, as you see on the right. Now, how are the incisions made? First of all, we're using the Bard Parker 15 blade just to cut the attachment and make a purchase point where we can take a tunneling tool and actually begin elevating the flap. And here we're doing it. And this is one of the tunneling tools once we've made a purchase point where we won't tear the flap. If you don't sever that attachment, the chances are you're going to tear that flap to some extent. So using sharp dissection, I would probably make that incision at least to hopefully 3 millimeters before I began elevating the flap. And here are some of the tunneling tools that you can get from many different dental supply companies. The vertical one on the left, and then you see the two that are for tunneling to the distal and to the right. But also a tool that I think you should have is this Hirschfeld file. It's a 1617. You can see the cost of it here with one manufacturer. And that is good for tunneling underneath the papilla from the facial to the palate to free up that papilla so that you don't get a crease. And we'll show you that crease in a minute. And the crease occurs right here. And so once you have tunneled facially on the teeth and laterally apical to the crease, then you want to take that Hirschfeld file and undermine as far palatally as you can, and that will release the flap even better. Here's the inbound outbound suturing technique that we're doing here. It's a little blurred, and here it is continued. But now here it is after we're through, and let's talk about it here in depth. Those are where we're going to pierce. Let's go back and look at that again. We're going to do our first pierce on the slide on the right. Then the second pierce is here. Then we're going to pierce here in the papilla that is not an interdental, a terminal papilla. Then we come back, see where we're doing it on the distal of that lateral, and then come back here and tie. So that's 1 suture, 2 sutures, 3 sutures, and the 4th suture. And I think you can visualize how that will really adapt the flap very well. And this is where you tie. So this is a 3-week post-op where we have almost 100% root coverage. And if we allow that to mature for, 4 or 5 months, 6 months, we didn't get complete root coverage. But now I know what's going through your mind. it didn't meet the criteria. Yes, we had apapillas. Yes, we had a class 1 recession. Yes, it was 3 millimeters vertically. Yes, it was over 1 millimeter thick, but there is missing root structure. So this points out how, as a periodontist, you can use this technique, because you always have the option of grafting underneath this. So what we decided to do on this case was to see if we could accomplish what we wanted with the coronally positioned flap, but we were fully prepared to use some grafting material. In all probability, when this case was done, that would have been connective tissue. Now let's talk about how I discovered the concept of the outbound inbound suture. Because prior to that I was taking sutures, as you see here, just suturing in the middle of the papilla, going behind the teeth and over the teeth, and you can see where the suture material was exposed on that central incisor on the image right. But you will also see that we did not get as good of adaptation to the root as we would like. So I started taking 5/0 sutures, and inside of that doing a little sling suture on each tooth to really snug that. So let's look where the concept came in. And we can see where we have the original suture on the left. Then you can see on the central incisor where we snugged it. We can see where we snugged it on the other. And therefore, look at them. That is basically the concept of the vertical, of the inbound, outbound suture. And how simple is this to do? This is a gentleman from Morocco, speaks French, and came with a group to NYU when I was lecturing. And having seen this lecture, he went back and took this case. And you will notice that the patient is missing some enamel. So he did do a class 5 restoration to restore a normal length tooth, and then he coronally positioned. And here we see not a great picture, but we can see the impact, and we can see the suturing, the inbound, outbound suturing that he did there. And this is about a 2-week post-op. So you can learn this from a lecture, and this is not a periodontist, this is a restorative dentist. And I think that all dental students need to be exposed to this concept and to look at their cases before they decide to do some type of class 5 restoration. Because restorative people are not aware of this, so we as periodontists need to make the general dentist aware of this, even in dental schools, and also take this out into practice and share it with general practitioners. Now let's talk about the combination technique. This is what I refer to as the gull wing technique, because the head of the gull is going to be between the central incisors where we're going to tunnel, and then distal to each central to the canine, we're going to elevate a flap with one vertical in the distal area, and that's like the wings of the gull on this. So the first thing that we want to do is determine is how much missing tooth structure that we have. And you can see that we do have caries on the lateral. We do have a shallow restoration on the centrals there. And if this patient came into the average dental practice, you and I both know what they would get. They would redo these class 5 restorations. But after root planing, we can see, and using a burr to kind of remove that on the central incisor, we see that we're not missing that much root structure, and we do have a nice thick biotype. Note that there's a minimal amount of root structure on the missing root structure. We're using the Papillae Deepithelialization technique in the on the gull wing part of it, and we're going to use the tunneling technique where the head of the gull would be. So we go in there and we deepithelialize that, and you can see the flap is flaccid, how we're bringing that to place. But we're pulling it slightly with a curette. We may not have that as mobilized as I would really like to. And here we see the pre-op view, and here we see the post-op sometime later. And you will notice on this lateral, we don't have complete root coverage, but with a minimal amount of root exposed there, by creeping attachment and proper brushing over a short period of time, that'll come right into place. So the question comes up. Would you rather have something that lasts over 3 to 5 years without cutting into the root, and something that is going to last forever unless the patient brushes it away. Another combination. Here we're going to use the coronally position flap on the premolars because they meet the criteria. But on the canine, we have a class II recession. So therefore, what kind of papilla do you have on the mesial of that canine? That's an A+. So what we decided to do here was to coronally position, as we see on the right, on the premolars, and we're making a vertical incision in the attached gingiva where you see the black line on the left. And then we're going to take that tissue on the canine and move it laterally to get complete root coverage. And if necessary, we would be prepared, if we were uncomfortable, of placing some connective tissue underneath that laterally positioned flap. So here's where we started. This is where we ended up. And you can see that we did get complete root coverage. But what do you see right here on the distal of that canine? A little redness. This is a type A patient and therefore has not changed her brushing habits. So therefore she's going to recreate the recession unless she starts brushing properly. But I mentioned the pinhole technique, so let's wind up with that. I took Dr. Child's course about 3 years ago and brought back some principles which I'm going to show you on this. Yes, I took his course, but no, I don't do the technique exactly as he presented it. Here we see on this canine a classic class II recession. Not only do you have unattached gingiva on the apical area, you have no attached gingiva. And before this case was treated, I absolutely would have said this case needs to be grafted. But I decided to incorporate some of the principles that Dr. Chow used, and I'll show you the results that I got on that. First of all, I'm using a fine diamond to go ahead there and freshen the root to get rid of that slickness, and also to remove any undercut that may be on the canine. Then we're laterally tunneling, and you can see the crease here where we went in and used the Hirschfeld file to undermine that. Now we've got some calcium sulfate here, and this is dampened a little bit. And here we see some calcium sulfate that we're going to use, and we're going to use some Colla strips. Now we're using medical grade Dihydrate calcium sulfate. We used to order this in bulk from a chemical supply company, and a pound of it cost about $60. But these people have gotten wind of this and are uncomfortable with us using this product intraorally, especially surgically. So you can no longer get it from that, but you can order it from Salvin particularly, and maybe other places. All right, calcium sulfate possesses angiogenic properties. That is, it stimulates blood vessel formation, and this results in more rapid healing. It can also be used as a binding agent in bone grafting, as an adhesive to hold the bone particles together, and that really helps in your bone grafting. Third, it can be used as a barrier to prevent epithelial migration, and it has been used in orthopedic surgery for over 150 years, so it has stood the test of time from a safety standpoint. But I said it must be ordered from a chemical supply company if you can get it, or you're going to need to go to a dental supply company like Salvin and order it there. So here are the damp strips. You've gotten a piece of Colla tape and you've cut it up into 5, 6, 7 strips, and those strips are wet, and then you put that and let them soak up the anhydrous calcium sulfate, as we're seeing here, and coating those strips with it. And this is the product information from Zimmer on that. These strips are 1 by 3 inches, and you cut them up into little pieces that are about 2 to 3 millimeters vertically and about the length that you're going to see in a minute. Here we see the strips that have been embedded with the calcium sulfate before they're inserted in the tunnel. And on the right, you can see after several strips, in this case probably 4 or 5 strips have been inserted. But the thing that I would like for you to note is look at the tissue contour apical to the incision, and notice on the right, by using that, we have created a thick biotype. And we're adding a little more calcium sulfate here, and you can see on the right the inbound, outbound suturing that we've done. But this was done by a resident, and I was really concerned because look, he left one of the collagen strips uncovered there. I think it's important on there to mobilize that flap where it will come down to the cemento-enamel junction so that all of your Colla tape coated with calcium sulfate is covered. I thought that might present a problem. So this is the way it looked with the suturing present, and this is the way it looked at 1 week post-op. Now you can realize residents are very anxious to see how cases turn out, and they like to see them at a week. Personally, I think you should wait 3 weeks before you look at the case to allow for more tissue maturity. But it's amazing to me, although we look at the margin of that tissue, apically to that, that's beginning to look like keratinized tissue. So a closer view of it, we see what appears to be a mucogingival junction forming. You tend to see what appears to be a free gingival groove, and a free gingival groove is the sulcus, will be the sulcus depth. So this is the way it initially healed up, and we're talking about probably about a month or so later. And then we see where the probe is that we did not get complete root coverage. Now, as I said earlier, typically if that dimension is a millimeter or less and you have a normal to thick biotype, that's going to creep right down. But will it happen with this technique? So here we see the pre-op, and here we see the slide 15 months later with complete root coverage, a thick biotype, and what appears to be keratinized tissue. So therefore, I hope I've given you some ideas on how to determine when to do a coronal position flap and several different ways of doing it. So let's see if we can cut out placing class 5 restorations and instead replace that with a surgical procedure that will last forever if the patient does not brush it away.